So I'm going to talk about a very common problem. Just as a show of hands, how many has had carpal tunnel? How many people have had carpal tunnel? Just one in the audience? Okay. So that's pretty good. It's a topic that many of you are familiar with and have treated, I'm sure. And carpal tunnel syndrome is this. It's compression of the median nerve. So the median nerve is this yellow structure you see in the middle of your hand. And it crosses this ligament, underneath this ligament, the carpal tunnel ligament. And in some patients, for some reason or another, which we'll get into, it's compressed. And when that nerve is compressed or pinched, you have these feelings of numbness, of tingling, and some patients even have pain that wakes them up in the morning. So how many people are affected? More than in this room, but it is the most common compressive neuropathy affecting the upper extremity, and many people actually stay home from work for this problem. The median time lost is somewhere about a month, so that's a lot of time lost in society just to this type of problem. What are the risk factors? This is something that's come up actually just this year. The American Academy of Orthopedic Surgeons published a new update. They've looked at the entire body of literature. They've gone through all the years and years and decades of research and looked up what may be causing this problem. And this is a very common question your relatives may ask you or your friends may ask you. So what are the facts? We know for sure that anybody who's doing any type of work that requires a high repetition rate using their hands or their wrists can cause this. We know for sure that anybody with a high BMI is at very high risk of this. So there's a direct correlation between your BMI and how much carpal tunnel pressure you have on that nerve. What else is new? We know some other things which we thought were myths before, like computer work, typing. Those are actually all true. So they've been proven over the course of the past few decades that computer work actually does have a direct correlating effect on carpal tunnel syndrome. Other things that we know for sure are any kind of job that requires vibration. So people who are in construction are often using things that can cause vibration like jackhammers. So that can definitely cause carpal tunnel syndrome. And things even, there have been studies actually looking at gardening. Gardening is a very common cause of carpal tunnel syndrome, which for our patients can be very common. What's more towards the fiction end and has not been proven yet, diabetes, which may be related, really hasn't been proven. It's not an age-related problem, so those of us who are younger or older really have no effect on that. Gender is not an issue. Drug use, smoking, race, these are all not issues or have not been proven yet. What are our treatment options? So if you're like me, I always look to Amazon if I want something. And this is a bracelet that they sell. It looks great. It's magnetic, and it's specifically for arthritis and carpal tunnel, so you get two in one. There have been over 475 reviews. It's 4.5 stars. So for almost anything else, you would probably buy this, but it even comes in rose gold, so it can match your iPhone. But this is what we really know. So what are the facts? We know wrist splinting works. So 48 weeks of just splinting your wrist can work. And the reason is when you splint your wrist, you're not moving it, and so you're not pinching that nerve. So that's a real thing that works. And we also start with cortisone injections. And I tell every patient this, a cortisone injection I think can be helpful because if you inject this space around the nerve, you're treating the inflammation and all that swollen tissue that's pushing on the nerve. So it gives the nerve more room. So that can help. Finally, this is something that I didn't know, but when I looked up the literature, it can really help. It's anti-inflammatory phonophoresis. So what that is a delivery topically of an anti-inflammatory that's been proven to actually work. And I'm sure a lot of therapists are nodding their heads. You know, it's something you've probably already known, but it can work. So that's been proven. And finally, if we move towards surgery, if all these other things don't work, that's 100% proven and has been shown in the literature to be very good. Magnet therapy we know is false, so don't tell any patients to use any magnets. Oral treatments unlike the NSAIDs that you can use through phonophoresis, oral treatments really don't work. So gabapentin, even though it may treat some of that nerve pain, doesn't really get down to the problem, so that's not something that I recommend. Oral steroids is still a puzzle to us, I think, because for some patients, like rheumatoid arthritis patients who have swelling and can have swelling around the nerve, that can help, but it's not a very reliable option, especially for those patients that don't have that type of problem. So I don't prescribe steroids for that. Finally, lasers. Patients love lasers, but it really doesn't work. So laser therapy has not had any proof behind it, as far as I know. So what types of surgery is possible? Most of you have seen or know about the open type, so this is very, very common. I think this is the most traditional type, and we know it works. And this conference has really been about trying to improve our outcomes and our safety. So this is actually quite a safe way to do carpal tunnel surgery. The question is, how do we make this better, and is it any better to do it any other way? And there has been a movement, really not so new, but there have been some interesting changes to how we can do it endoscopically. So endoscopically means we use a much smaller incision for some people, but a small incision at the crease of the wrist. And we'll talk about the reasons why this might be a good option for some patients. Not everyone, but a lot of patients can benefit from that. So here's a diagram of what it might look like in the operating room. The endoscope is used through this proximal incision, and unlike the old traditional endoscopic methods where you may have had to use 2 incisions, which added up to pretty much the same incision if you do it open, you only have to use 1 small incision proximally, and you use a clear cannula now. So many of you are familiar with arthroscopy, where metal cannulas are used. This is different because this is a clear cannula, and I'll show you the benefit of that when we're doing this specific type of surgery. This is an example of us using it in the operating room. So you have an endoscope in the right hand and also on the right side, and also this special tool that we use that has not just the clear cannula, but the blade also. So everything's all in one in this particular system. Here's a video of what it looks like as we're entering the carpal tunnel. I'm just going to orient you first. On the right side, what you see is the median nerve. So this is the nerve that's pinched. We're inside the actual carpal tunnel, and above us in the ceiling is the ligament. So all these white fibers, those are the ligaments looking up as if you're inside the tunnel, and the nerve is on the right. And on the left, you'll see will be some tendons that are also in the same canal. So you can see the nerves and the blood vessels that are in the nerve, the ligament above, and we're going to move the fingers, and you can see the tendons glide on the left. So it's a great picture because you know exactly where everything is. There's no confusion. With the clear cannula, you can see everything and all the anatomy. So this is us now taking that same view. We're going all the way down distally towards the middle of the palm, and we see the palmar fat, which is our guide to where we stop. And we're taking this knife that's built into this system, and we're cutting the ligament from the inside out. So rather than making the open incision, we're cutting the ligament from inside out and going down, looking at the ligament as it's being cut. So the theoretical benefit is this. So all this muscle that's above, that's superficial to the ligament, is not touched. So all of this muscle that we would typically cut as we're going through the open incision up here is not disturbed. So some patients feel that it is a real benefit in terms of pain and also the recovery. And I'll show you some data that supports that. Here we are looking at both sides. You can see it's wide open. And finally, we'll show you a picture of what the end result is. It's a nice wide open release. The ligament is fully cut on both sides. The nerve is still down here, and it's very safe on the side, nowhere near where the knife was. And then let's talk about the evidence. So I think that for many surgeons, there has been a hesitation to actually move to this because, 1, it can cost more, and 2, some people think it doesn't work as well. But the literature really doesn't support that. So in a randomized trial recently, it is proven to be less painful. So that's great for patients. That means for them less narcotics, just like Dr. Sethi talked about. It also means in this specific meta-analysis, which is a very high-level type of analysis for randomized trials, it was a faster return to work. So patients get back up to 9 days back to work faster than if they had it done open. So it's a real difference. It's not just 1 or 2 days. And it has been proven to be equally effective. So whether or not you have it done open or endoscopically, it's the same effectiveness. We're doing the same surgery. You're releasing the ligament. It has been also proven to actually have a faster return of strength. So this was done as a meta-analysis also recently in 2014, and it shows that you do have faster return of strength. And rather than being slower, most people, when they use some similar system or this one, actually have faster operative time. So what that means is you have a smaller incision, you can close it faster. There is some setup involved, but most of the time over the country, it's been proven to be about 10 minutes faster than an open carpal tunnel. So you're saving operative time, you're saving operative cost. And there's no difference in major complication rates, including return to surgery. So it is a good surgery with no difference in complication rate. And this is also supported by very recent literature. And that's it.